Dear viewers, welcome you all to our show, OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is bone transport of tibia by the magical Elizarov. And before starting our program, I would like to remember those martyrs who sacrificed their life in 1952 for the sake of our mother tongue, that is Bangla Bhasha. And for the honor of them, the UNICEF declared the 21st February as an International Mother Language Day. We are very proud as because of we are Bangladeshi, we are the first nation that we fight for our mother tongue. সকল ভাষা শহীদদের প্রতি আমাদের শ্রদ্ধা জানিয়ে আমাদের আজকের প্রোগ্রাম শুরু করছি। Dear viewers, today our speaker is the very famous Elizarov surgeon in Kurdistan, Iraq, Professor Omar sir. I would like to request Professor Omar sir to join with us.
Okay, thank you so much. Good afternoon. Happy Friday. I hope to enjoy.
Good afternoon, sir.
Good afternoon.
Dear viewers, we have three learned academic experts with us. One of them is the legendary Elizarov surgeon, the one and only, the Professor Mofakkarul Barisal from Bangladesh. I would like to request Professor Mofakkarul Barisal to join with us. Professor Mofakkarul Barisal, would you please join with us, sir? I think there is a network problem.
I think. Now it's okay?
Yes, sir, it's okay. Welcome, sir.
Okay.
Welcome.
Good afternoon, everyone. Thank you very much, Tanveer and Professor Umar. And we're gladly waiting to hear your voice. Thank you.
Thank you so much.
Thank you very much. Thank you very much, sir. And dear viewers, we have another enthusiastic Elizarov surgeon from Patna, India, Dr. Shamsul Huda sir. I would like to request Dr. Shamsul Huda sir to join with us. Sir, welcome.
Thank you. Very good. Thank you. Very good. Good afternoon and greetings from India.
Thank you very much, sir. And dear viewers, we have another learned academic expert from Kurgan, Russia, that is Professor Novikov sir, and he will join in the coming part of our program, we hope so. Dear viewers, as we all know that the topic is bone transport of tibia by the magical Elizarov, and the speaker is Professor Omar sir. I would like to request Professor Omar sir to share his screen. Sir, would you please share your screen and start your presentation?
So much. Okay. Next slide, please. Okay. My subject is about bone transport of tibia. Let us to go to the next slide, please. Can you shift?
Next.
Yes. Next one also, please. I have a special interest with limb reconstructive surgery and bone elongation based on the principles of Elizarov. So probably I visit Professor Barry several times outside of my country, whether in India and America and so on. So anyhow, I am much more impressed about Elizarov principles as we are saved a lot of limbs from amputation and the patient will turn back to their activities. Okay, next slide, please. Okay, really, this is one of the published paper in European Scientific Journal 2018 about the comparative study to evaluate the outcome of 40 patients with bone loss in tibia. In one group, I used conventional external fixator, monolateral or bilateral. In the other group, I used Elizarov type of the external fixator. So accordingly, I assessed the outcome of these cases based on the ASAMI scoring system. Although nowadays I have much more cases like this, I have 97 cases, but just 80 of them were involved in this published paper. Next one, please. You know that why there will be bone defect in one of the long bone, either because of infection and repetitive wound debridement and schistory will come out, or when sometimes we are resecting a bone tumor, so there will be a good gap, or sometimes as a result of trauma itself or the result of the repetitive surgeries. Gradually, you will see that there is a gap. How we can fill this gap? Next slide, please. Really, we have 9 options. The last one, which is amputation, which is again is the limb reconstructive surgery. The first one is bone graft, either in the form of cancellous or vertical, but as a general, in the majority of the papers saying that whenever the length of this long bone is more than the diameter of the bone, bone graft will not be useful. Another method, either to do bone shortening if you have, for example, 1 centimeter, easily can be compensated by shoe raising, or sometimes we have shortage of the facilities. I have cases before 22 years. Obligatory, I did shortening 18 centimeters. As far as the patient was refusing amputation. After 17 years, he returned back when he saw me in TV. This time there were Elizarov frame which were available. I did bone transport, bone elongation at 2 sites. So bone shortening is another method of filling of this gap. Sometimes you can do immediate bone shortening followed by elongation, or another method, there is a vascularized fibular graft, which is very expensive, which needs microscopic surgery and which needs a very well expert people who are dealing with the microscope. Another method is fibula pro tibia. Really, I am using fibula pro tibia for cases of big gap when the infection is subsided. Nowadays, I have 2 cases of tibial hemimelia even. I use the fibula as to be put in the same line with the tibia. Metallic bone cage is another method in which the cavity will be filled with bone graft. Another method is the French method, which is musculate. As you know that we are using bone cement to give better mechanical stability. At the same time, biologically, there will be liberation of some biological material to stimulate bone formation. But the last, before last and not least, is the bone transport. Bone transport is different from the other method, is that, as we know, one of the important discovery of Elizarov is bone transport. The only 2 tissues in the body undergo regeneration is liver, in which we are 2/3 of the liver will be removed and the other tissue will be bone under tension. So there is no any other method better than bone transportation, because there will be full regeneration of the bone. Even nowadays, as you know, it is known as destruction histogenesis rather than destruction osteogenesis. The entire tissue undergo new tissue formation, even the skin without skin graft, even the vessel and arteries. And you know that sometimes they are using for the treatment of Berger disease, thromboangiitis obliterans. Lastly, if you are hopeless, we may do amputation. But nowadays, because of the development of limb reconstructive surgery, amputation will be minimized. Next slide, please. This was the scoring system of the association of application of method of Elizarov. We are depending on bony result and functional result. In bony result, we are depending on the union, presence or absence of infection. Deformity, as you know that the components of deformity are angulation, rotation, translation, and length. But here in this scoring is speaking just about the angulation and shortening. If it is angulation more than 7 centimeters, and you know that angulation also, it depends on the plane, whether in the sagittal plane or frontal plane. In sagittal plane, angulation will be much more tolerated by the patient because of the mobility of the ankle, knee, and hip. While in the frontal plane, it will be much more obvious, and it is not so good tolerated by the patient. So according to this scoring system, we assess the bony results. While the functional results, we have 5 data. One of them, whether the patient is active, return back to the previous job, whether there is limping, whatever the cause of limping, whether there is stiffness or limitation of movement of the ankle and knee, less than 15 degrees, also whether there is reflex sympathetic dystrophy or there is insignificant pain. Accordingly, we are assessing the patient. The last one, when there is failure, it means that there is amputation. But fortunately, none of our cases will ended by amputation, as from the beginning there was good vascularity of the ankle and foot. Next one, please. So according to this scoring system, we can see that the cases are distributed. As a general, the group which are treated by Elizarov frame giving us better result. The reason is that instead of using the Chance pin or Denham pin, in Elizarov they are using wires, which gives micro motion, which is a good stimulus for osteogenesis. Not only this, in Elizarov frame you can correct different types of deformities. and there is no chance of angulation, unlike of unilateral external fixator. Next one, please. Okay. So some of our cases has some complication like residual limb length discrepancy in 4 of the patient, which was maximum 1 centimeter compensated by shoe raising, and 3 of the patient from the group A, it means those with conventional external fixator, while 1 of the patient, it means 5% from the group B. Another common complication of external fixator, as you know, pin tract infection. 3 of them were graded as grade 2 according to Checkett's classification. They were treated by proper hygiene and antibiotic according to the culture and sensitivity. 2 of the patients had grade 3 pin tract infection, and they were treated by change of the pin in the theater, while in group B, it means Elizarov group, 3 of the patients had pin tract infection with grade 2. They were treated just by oral antibiotic and good personal hygiene. Next one, please. Yes. Sometimes you will face with Equinox deformity, in which the bone is elongated, but the muscle is not elongated. So 4 of the patient with group 4 developed Equinox deformity. We treated by elongation of tendon Achilles and night brace. While regarding reflex sympathetic dystrophy, in 4 of them were takes place. In group number A, 2 of the cases, they developed knee joint stiffness, 4 of the cases of the ankle stiffness, while in group B is less, just 2 of them with ankle stiffness and knee stiffness. Only 2 patients, it means 30% from group A and 1 patient from group B have incompetence to their previous job. Refraction in only 2 of the patients from the group B. These are the associated complications as a result of our treatment. Next slide, please. Okay, this is one of the patients. We can see that 11 centimeter shortening clinically, 3 centimeter radiologically, so totally 14 centimeters, 11 operations done before he came to me. Next one, please. Yes, we can see multiple operations, including skin graft, nerve graft, bone graft, and so on. So next one, please. Yes, we can see that there is 3 centimeter radiological shortening, while 11 centimeter clinically. We can see that the nail is migrated toward the talus. Distal screw is broken. Next to the distal is about to come out. Next slide, please. The same patient, we removed the intramedullary nail then we applied the Elizarov frame. In the beginning, it was just 4 rings to compress the non-union side and gap, and proximally and distally to do elongation. Next one, please. Okay. After a few weeks, the patient developed Equinox deformity, although I told him that he should do good physiotherapy. Also, he should do night brace, but he didn't. Anyhow, I extended the frame to include the ankle to do correction of the Equinox deformity. Next one, please. Now we can see the patient is stand without any more wooden block under the shorter side. He is wearing the ordinary shoes, and the limbs are equalized. Next one, please. Yes, the radiograph of the same patient, there is very nice corticalization of the destruction side. There is union also of the docking side. Next one, please. Okay, another patient, really this is a 28, he was a 28 years old man with chronic osteomyelitis of the left tibia for the last 20 years as a complication of fracture and tight bandaging, causing cellulitis, osteomyelitis, and the patient was refusing amputation. In the springtime, when there is more activity, there were some sequestrae were coming out, and the patient was walking with crutch. Next slide, please. Yes, this is the Galiazi test. As you know that not only radiological, there were 11 centimeter. Clinically, also, it's about 10 centimeter, but this shortening is a combination of true and apparent because of the bowing of the tibia. Next one, please. Yes, we can see that the patient in prone position, how there is shortening, but this clinical shortening is a combination of true and apparent because of the bowing of the fibula and absent tibia. Next one, please. The radiograph of the same patient, AP and lateral view, multiple sequestrae, bowing of the fibula, ankylosed ankle, and there is a good gap in the tibia. What I did, I applied 4 frames after I cut the fibula and I put into the tibia. It means fibula protibia. Why I use the external fixator? To compress the side of fibula protibia, at the same time to do correction and elongation of the side proximal and distal. Next one, please. Yes, now we can see that the middle block of the Elizarov I removed, and I added another 2 pins that the distal part of the fibula invaginated into the proximal part of the tibia. Next slide, please. We can see still the lateral view of the same patient, that there is corticalization of the destruction sites and hypertrophy of the fibula. Next one, please. Well equalized limbs, no more sinus discharging pus, but there are irregular scar tissue of previous wound debridement done by other surgeons. Okay, next one, please. Now the patient is standing without any support and there is no shortening. You can see that the fibula is inside the tibia and hypertrophied. And there is very well corticalization of the destruction sites and union of the docking sites. Next one, please. This is the lateral view of the same patient. Next one, please. Okay, thank you so much. Zorspas, that's in Kurdish language. Thank you so much.
Thank you very much, sir, for your excellent presentation. And now I'd like to request Professor Mofakrul Barisar to say something regarding the presentation. Professor Mofakrul Barisar.
Thank you, my friend.
Thank you so much.
Good cases you have shown. And only I would like to ask you the one question.
Yes, please.
Regarding the knee stiffness after doing surgery, you told in 2 cases in the knee stiffness and 2 cases in the ankle stiffness. What you did with this patient, or what you counsel your patient regarding that?
Just by physiotherapy, after the removal of the frame, they return back to the normal. Except that one with ankylosed joint. The ankylosed joint is already, there is no movement.
Yes. So you did not do any kind of Judaic quadriceps plasti?
No, in this group, no. In this group, no.
And but in the ankle, you have not done any distraction of the ankle joint, no?
No, but I have another series of
Thank
cases.
you very much. Again, these are the cases that we are also facing in our country. Pro tibia, the 9 points that you have mentioned is very good. And these are the sequentially you have treated. And you know, the fibular grafting, vascularized, it is difficult, long time, and cost effective. And you know, and that's why we are also not doing that.
And you are injuring the other side. You are injuring the other leg also. This is another problem. Yes, thank you.
And Elizarov, the really best choice. I don't know whether you are using chance pains in tibia. We are not using any chance pains. It gives rigidity.
Yes, exactly. I'm using hybrid.
Yeah, hybrid. Thank you very much, Omar. Thank you. Thank you. All the best.
With pleasure. All the best.
Thank you very much, sir, for your nice discussion. I have a question to Professor Omo, sir. Sir, before removing the frame, do you use any dynamization period? This is my first question. And the second question is, after removing the brace, after removing the frame, do you use any brace for your patients?
Regarding dynamization, sometimes I am using, even sometimes I am doing accordion procedure to do compression, to do distraction. And regarding the brace, definitely, whenever I am removing the frame, almost always I am prescribing brace in the form of CAFO in these cases, knee, ankle, foot orthosis, till I will see that there is no more any sort of defect in radiologically and the full range of movement, then I will tell the patient to remove the brace completely. I think one of my cases was using the brace in the presentation.
Yes. Okay. Thank you. Thank you very much, sir. Now I would like to request Dr. Shamsulhuda sir to say something regarding the presentation.
Thank you, Dr. Tanvir. Congratulations, sir, for very wonderful cases, legendary cases. We are regularly facing this side of cases in India. So many cases of infection, non-union, using elixir for bone transplant and all. So my question to you, sir, what is the incidence of refracture after bone transport and reinfection? Sir?
Sorry, the chance of what?
Refracture.
Refracturing. Chance of refracturing, usually it is little as far as we are prescribing brace after removal of the external fixator. In case of trauma, very low chance of refracturing. Thank you.
And any cases for infection, the pentagon infections, in this case, for long time elixir?
Yes, we faced with some of the cases, especially that case with fibula pro tibia. So I removed the middle block and I put another wires or sometimes another sheets in another corridor.
So my question extends to Bari, sir. The same question you asked, sir. So in long duration bone transport, we frequently get knee stiffness and ankle stiffness. So what is the incidence of quadriceps and ankle restriction we used to do, sir, in these cases, sir? And what is the success rate, sir, after that? Sir, please unmute, sir.
Professor Umar sir, can you hear us, sir?
I hear, but I think he's asking Professor Bari.
Yeah. Can you hear me?
Yes, sir. Yes, sir.
So listen. This is my observation and what I have seen, especially when you are doing Elizarov in the lower end of the femur and upper end of the tibia, and any case of Shaskar type 5 and 6 particularly, and supracondylar comminuted fracture interarticular. Whenever you are using plates or Elizarov, in most of the cases you are getting the knee extension contraction. Okay? Knee extension contraction. That means you're not willing to able the flexion. And I'm getting a lot of cases in my country, and I am doing Judaic Quadriceps Plasti. Before I did that 5 steps of Judaic Quadriceps Plasti. Now I love to do the 3 steps of modified Judaic Quadriceps Plasti with traction in the patella. It's very simple case. If you do a release from the medial side, from the lateral side, lower 1/3 of the femur, and just below the patella, go up to the tibial tuberosity and release from the medial side. If needed, you can go for fractional lengthening of the tensor fascia lata. Otherwise, you don't need to go for proximal, that is in the proximal region of the femur. And in the same sitting, you put the K-wire, pass the K-wire through the patella and do the traction, that is hanging traction, in the vertical way for 10 to 14 days. And gradually, you will get a lengthening of the femur, biceps femoris. After that, you just remove the traction and then go for, physiotherapy with CPM machine. And I'm getting very good results. These are the, if you want to do the only Judaic Quadriceps Plasti, there is very massive operation. You need lots of bloods. And that is also giving, irrespective of any kind of stiffness, you'll get a very good result, fantastic result. And both the cases, that is Judaic Quadriceps and the modified Judaic Quadriceps, I had the publication in Medcrave. You can see that one. Thank you very much. This is my observation, and I'm doing that. Okay.
And in the ankle, sir?
In ankle, listen, ankle, whenever you are getting, if you see the X-ray findings, there are 2 classifications. There is Kellgren, and another one is Ahalbach radiological, which we are using in knee. When you are getting, that is your ankle is stiff, you can go for again distraction of the ankle joint. I go for more than 10 days or 15 days widening. As a result, same in Parthes, in knee osteoarthrosis, in ankle osteoarthritis, you can do that. And as a result, you will get a very good, circulation in the ankle joint and the movement also. And I do that. Ankle osteoarthritis, what we are doing, most of the young orthopedic surgeons, they give always NSAID or putting the injection, steroid. That is not the ideal treatment.
Right.
You must increase the circulation and you must increase the joint space. And after that, you will get a good movement. And patient will feel pain-free movement. This is the, my observation and what I am doing. Thank you.
So, sir, while distraction of the ankle, do you also apply hinges for the movement, sir?
Yes, you can. You can do that. You can apply the hinge just below, at the region of the tendinoachilles. You put the hinges like that, and in the foot you can put arch, half arch, and in the tibia you can put two block, and do the distraction. You don't need to open anything. And one thing I'm telling you, ankle osteoarthritis in the distal tibia, in the metaphyseal region, what Shipsop showed me, and I'm doing that, you just go for drilling by 2K in the metaphyseal region. You can increase circulation. In the metaphyseal region, go first cortex and don't hit the last cortex in the metaphyseal region. Do drilling with 2 mm K wire or drill bit. You can get a good circulation, and this is established, with ankle distraction.
Right, sir. And sir, what is the rate of success after doing the distraction? Does it relapse to the stiffness again, or it is the movements there, sir? What is the success rate, sir?
No. You'll get the rate of success if you follow the basic principle. You just start distraction for 10 to 15 days.
Right,
Keep the apparatus for another 3 times. You have done 15 days distraction or 10 days distraction. Keep it for another 3 times. Then you remove the apparatus and do the exercises accordingly. That is physiotherapy. And at the same time, you do the distal metaphyseal region drilling. Don't fire the second cortex. And I tell you,
sir.
You'll get a very good result.
Okay, sir. Right. Thank you, sir.
Thank
Thanks
you.
a lot, sir.
Thank you very much, sir. I think that's a very new thing to all of us, as because of we came to know from Professor Mofakarul Bari, sir. Hope we can show in our coming presentation the Elizarovin ankle osteoarthritis.
Yes.
We can present it. Yeah, that can be a presentation also.
Knee osteoarthritis and ankle osteoarthritis. I'm
And you can elbow, sir.
without any
You can elbow, sir.
hesitation, I am randomly doing. Why? Because we are using either, steroid injection.
Right, sir.
Most of the cases or PRP,
Right, sir.
TRP, steroid injection.
Yes, sir.
But if you do
Steroid,
the
yeah.
distraction, if you do the principle of Elizarov, okay, what every time I'm telling, slow and steady traction on a living tissue creates a stress which is metabolically activated in biosynthetic and proliferative pathways, depending upon the biosynthetic and proliferative pathways, depending upon the vascularity and the functional use. If you have a vascularity little, if you use that one with Elizarov apparatus, you will get. This is the Elizarov's principles and law. And I always keep it in mind. Whenever you do any distraction in any joint, nothing to lose. Nothing to lose. This is the principle.
Thank you, sir.
And at the same time, I'm telling you, in knee osteoarthritis, I am doing 22 tunnelization. That is called microfracture. Tunnelization or microfracture is the same terminology. You take the K-wire from the patella upper pole, right and left side, drill, lower patella, drill, and lower femur from top to bottom up to subchondral you drill, from medial to lateral, again from tibia, from lateral to medial up to subchondral region you drill. 22 drilling you did, and you go give the distraction. You will get a
So
good
we'd
result.
like to have a talks on this, sir. Detailed talks, sir.
Okay.
Yeah,
I'll
yeah,
show you.
yeah. Definitely,
These
sir.
are the
Definitely. I think
by Elizarov, you could do, lots of people they don't know. I'm telling you,
yes,
just discussion. One of our renowned general surgeon, he's working, I'll not tell, senior, regarding the PVD, peripheral vascular disease, and distraction osteogenesis. He heard the name, only the distraction osteogenesis, but the neurogenesis, angiogenesis, he doesn't believe. Now, how you can make him understand? That is the theory, a law. You should know that. And we are working, we are getting good results. And this is established, not that I am telling or you are telling. This is established. This is established on the basis of animals in Kurgan, they have shown, and we are getting good results. That's why I confidently always tell, you do this, you'll get a good result. Okay? So
yes.
thank you.
Thank you, sir.
Thank you. Thank you very much, sir, for your great message. Sir, I have one question to Professor Omar, sir. Sir, you transport the fibula in a same day, or you gradually transported the fibula to the tibia, sir?
In the same day, usually when there is no evidence of active infection, because this already a case of chronic osteomyelitis. So I'm not afraid from that. In the same day,
Yes.
if there is no active infection. But if there is active infection with severe soft tissue swelling, definitely you cannot do it. You have to postpone it till the active infection will be subsided. Do you get my?
Okay, sir.
Okay.
Yes.
I would like to add one point regarding the arthrodiastasis. I have one case published in the Elizarov journal about treatment of acquired flat foot, in which I did gradual arthrodiastasis. Now I have the follow-up for the same patient for 6 years without any sort of osteoarthritic change. I will send you the link to see that journal. Thank you so much. This is in confirmation of the speaker. It is
Yes.
in confirmation. This is in confirmation of the points told by Professor Barry.
Yes.
Yeah, that's great, sir.
Thank you so much.
AHD. And that's why when patient comes to me
Yes,
with knee osteoarthritis, or
exactly.
I tell always osteoarthrosis. I never tell this osteoarthritis. I tell osteoarthrosis. Why?
Arthrosis.
This is the degenerative and dystrophic change.
Yes,
Degenerative and dystrophic. Most of the people, they are telling everybody orthopedic osteoarthritis.
Yes.
Better to, I learned this terminology from Russians. They never tell osteoarthritis. They told osteoarthros. That osteoarthrosis means degenerative and dystrophic change. Two things. That's why whenever patient comes to you with osteoarthrosis,
yes,
grade 1, 2, 3, 1, you can really give treatment with the NSAID or exercise. 2, 3, 4, Ahlbach type or Kelly-Green-Lawrence type. Then you go for AHD. I write management plan, AHD, articulated hinge distraction with microfracture or tunnelization. This is the treatment. And this is, I have publication, and American, Russians, they have lots of publications.
yes.
Lots of publications. And my friend Omar is doing, I'm doing, lots of people are doing. I don't know who will start on doing it within a short time. Do it.
Sir.
Yes.
Nothing to lose with
Yeah.
Elizarov.
Yes,
If you
sir.
love Elizarov, just like your wife.
Yes.
Right, sir.
Yes, sir.
Thank you.
Thank you.
Thank you very much, sir. That was a great message. We always say that the Elizarov is magical. Yeah, it is definitely magical, like our wife also.
Exactly.
So it's a great day for us. And thank you very much, our honorable speaker, Professor Omar sir, and thank you very much, Professor Bafakarul Bari sir, for giving us lots of informations and lots of knowledge. And definitely, I would like to thank Dr. Shamsul Huda sir for being with us and sharing his knowledge with us. I would like to thank Rajtv for helping us to arranging this type of academic program, and definitely Renata Pharmaceuticals Bangladesh Limited for sponsoring our program. I'm Dr. Mohammad Tanvir Ashraf saying bye-bye today, and hope we will connect in the coming Friday with another magical Elizarov topic. Till then, I would like to say bye-bye to all of you. Bye-bye.
You are watching Rajtv, Jagorone, Bangladesh. Please subscribe our channel.